Rural healthcare has had some long-standing challenges, including limited access to specialists, a shortage of healthcare providers, and significant geographic barriers that make it difficult for patients to get the care they need. As technology advances and new care models emerge, the future of healthcare is being reshaped, and specifically through expanding access to care through telemedicine. How can we ensure these advancements reach the communities that need them most? Today's guest, Karthik Ganesh, CEO of OnMed, is here to talk about it. Welcome back to Healthcare Rounds, your insider access to the healthcare industry. I'm John Marchica, CEO of Darwin Research Group. Today, I'm excited to bring back for a second time Karthik Ganesh, who is CEO of OnMed. We got a lot to talk about today: rural healthcare, what's going on at OnMed. So I'm really excited. Karthik, thanks so much for coming back to Healthcare Rounds. It's really great to see you again.
Yeah, likewise, John. I really enjoyed our last conversation. It's been a while, and it's a completely different facet of healthcare we're talking about today. So I'm looking forward to our conversation.
Absolutely. So, well, with that, I know there's a lot of people who listen to healthcare rounds. They listen to every episode and they can probably go all the way back to 2018. Um, but there are those who may not know you. So, can you give us a little bit of an introduction about your background? And then my first question is going to be what made you transition to OnMed? So, I guess that's where you could end up.
Sounds good. Nearly 25 years in healthcare. I'd like to think I've been privileged to have touched healthcare from all the angles that there are to touch it from. I've done the consulting part of it. I've run a TPA. I've run a PBM. I have helped stand up a value-based company, and I helped Cigna launch it and run it. Um, Health tech. I've again provided sponsored health plans. I've touched it from a lot of different angles, and and what you realize more and more over the years, the longer the time you spend in this, longer the time you spend in this industry is, uh, you'd like to think you come away with a lot of best practices, but you look at the industry and you realize, especially healthcare in America, there are more lessons learned than best practices coming out of it.
So true.
And and so I left my last gig back in 2023. I was burned out. I needed a break. I took a really great break. But what was important to me coming out of that was finding an organization or finding a fit that just didn't have a. It wasn't just about a mission. Sometimes the word mission gets misconstrued because I'd like to think terrorists have a mission as well. We may not like it, but they have a mission in their minds. I wanted an organization that just had a purpose, and the way I distinguish one from the other was a purpose is something that's societal, that's larger than ourselves, and has the ability to touch the lives of millions, or at least a lot of people. And and when we think back to maybe the last 50, 60 years, whatever, of healthcare policy in the US, it's either been about access or cost.
Hmm.
Cost can sometimes be you can have a peanut gallery in terms of whether you've actually made an impact to cost or not. Access is binary. You either made a difference or you did not.
Hmm.
And so I was looking for an organization, looking for an opportunity that had an incredible purpose, with where success and the ability to make a very significant dent in our healthcare challenges was very obvious, and OnMed was a perfect fit.
Karthik, I can completely empathize with your goal and what you were trying to accomplish in going to OnMed. And it's timely because actually Friday we had our Darwin Research Group, annual kickoff meeting where we go off site and we talked a lot about purpose. And with a market research company, it's sometimes a little bit of a struggle to say, well, how are we making a difference, and where do we want to make a difference, and how can we make a difference in those areas where we're not? I think you've stumbled upon something quite tangible, which we'll get to. Um, but even just the discussion with everybody last Friday was really terrific. And just understanding, kind of like the bigger picture, and how, I mean, our purpose statement is we leverage the power of information to enhance human health. That's a big, you know, enhancing human health through market research. Maybe not, but do we partner with those companies? Are we enabling those companies? Or are we working with those organizations that do that? And so, sorry, I didn't mean to get us off track right off the bat, but you
Makes total
you really
sense.
hit it when you said that, as and looking at OnMed and an organization that really is making a difference. Um, so, what are some of the things before we get in? Well, before we get into, I guess, the details of OnMed, were there, in all of your 25 years, were there some lessons that you were bringing to OnMed as CEO? Some things that you said are you wanted to accomplish, or some of those lessons that were pretty apparent that you wanted to share with your team? What were some of the things that you brought with you to the table that you're starting to see realized today, a year later?
That's a great question, John. Here's the way I think about. We've got some incredibly talented people in the healthcare industry. I feel one of the biggest challenges we've had with that talent pool has been people who keep doing the same thing over and over again. And you've got health plan people who spend a career, incredibly talented folks who make a career out of health plans, or
Hmm.
PBM folks who make a career out of PBMs. Uh, when you essentially circulate yourself around the industry, you realize two things. One, actually, I'm going to say three things. One, the challenges that are being faced in one aspect of healthcare have, in some cases, had solutions in other parts of healthcare. The inability to connect those dots because of just a lack of experience in both of those segments has stymied us over the years.
Because
There are
being
things that
siloed, right?
they're siloed. It's a silo. It's the age old thing, right? You can't connect dots. You know what you know, right? That's one
Mhm.
component to it. The second thing is that I would call out is that moving around healthcare as much as I have has given me a very healthy dose of pragmatism in terms of um, my solution orientation and the way I lead and the way I think, because I'm I'm not. I'd like to think that my value prop has, as a result of my circulating across healthcare, my value prop is big picture thinking, but grassroots execution. Because at that point, you know what's going to work, what's not, and you want to fail forward, but you also want to fail forward in a very pragmatic manner. Right. That's the
Sure.
second thing. The third thing I would say is the American consumer is very different from the American patient,
How so?
and I would say when I would say a couple of different things. One, you think about digital health. I don't remember the last time I walked into my bank. There is no facet of if most things in life outside of family, if most things in life for us converge around health and wealth, from a wealth standpoint, we are completely comfortable navigating all aspects of our wealth related interactions and transactions with people we work with over our mobile devices. Not the case in healthcare. In healthcare, I mean, we continue to see, right? Digital health adoption is sub 7, 8%. That's one. Second is you take that one step further as the American consumer understands their data might go places, and whether it helps them become smarter shoppers, it helps the industry what helps the industry tailor what they're selling to them, whatever the case might be. There's been a semi acceptance of the fact that there is data mining in play, and maybe it helps me or it doesn't help me as a consumer. The American patient is consistently paranoid. If I were to fill out a health risk assessment and I were to tell somebody I smoke, will that data now hit my life insurance company? Will they now jack up my premiums as a result of that? There's a
Sure.
very healthy paranoia. It's a second part to it. The third, just taking the paranoia theme for a second, the last thing I would leave you with is, for arguably the greatest country, a country with a strong consumer orientation on the planet, uh, the American consumer feels liberated, feels they can buy anywhere, shop anywhere. Their dollar can go as far as they want it to go, or as far as the market will let it go. So there's a level of liberation that comes when you operate as a consumer. There's a level of claustrophobia and uh, being cornered that you feel as the American patient, whether it's the insurance industry that's cornering you, whether it's your benefits and the limitations of your benefits, whether it's your frustration with the cost structure, whether it's your frustration with access to care. There are just so many things where you feel like you're cornered and you have to deal with the hand you've been dealt, which creates a very different psyche for the American patient. And I've consistently noticed you could have the exact same person who could be chest thumping as the consumer and then cowering as the patient. And it is just uh, a fascinating exercise in human psychology to observe the exact same person have two very different facets to the way they respond to different facets of our lives.
And I wonder too, if that general acceptance, um, in sort of like the first world of commerce and everything else, and sharing data and sharing information, little bit of a generational difference. I see how my daughters are, actually all my kids, how they are with technology and how they are with their phones and what they're willing to share, um, versus versus me. At the same time, as you said, I'm aware of a lot of the sharing that goes on. I'm aware that Amazon probably knows more about me than my wife, just by my purchasing patterns. But when it comes to healthcare, and the thing that always gets me is even the people who are in it. I mean, I'm pretty knee deep in healthcare, at least from a business and
Hmm.
policy perspective. Um, but when I engage with the system, always a problem. There's always issues. There's always something, um, not so much around specific payments, but that will rear its head sometimes. One of my daughters is a nurse, relatively new nurse, but trying to understand how how her healthcare benefits play out. And she has something specific with her eye that needs to take care of, and how to go about doing that. And she doesn't know what she's doing. And it's not that she's not bright, because she is, and not that she doesn't understand how to deliver care to patients as a nurse. She's doing great as a young nurse. And so I understand that dichotomy. And it's I suppose where we're going to go is to one of those solutions, right? Um,
That's exactly
in
right.
in OnMed. Um, but one of the things that I thought of before we get to OnMed, I want to just take us on a little different path for just a second, because it seems to me that, especially in rural healthcare or difficult to obtain healthcare, that your model is going to work really, really well. It's going to be very, very effective. I also think that it would be great here in Scottsdale. So it's not just something limited to rural. But what is it about, you know, I think we would all acknowledge that taking care of patients outside of big population centers has always been a problem. And we talk about access to specialists and some other things, but for in your mind, now that you've well been in healthcare 25 years, but now specifically with OnMed, what are some of those challenges that the typical and rural isn't even it? Because if you get in your car and you drive from New York across the country, or Chicago across or from here, from Scottsdale to the fires in LA, that's where America is. That's where people live. It's not like it's just vast nothingness. This is where a lot of people are living in places that aren't major population centers. So what are some of the things that you think of that are particular challenges with this set of folks? that's not a small subset. That's a very large portion of the American public.
Yeah, John, I would go as far as saying that this is it's an unpopular thing to say, especially for someone who's been in healthcare for 25 years, but our system is broken. There is not a doubt about that. It doesn't mean that there aren't a lot of people who are trying to improve it. But the system is broken, and that starts with the entryway to the system with healthcare access. Um, this is not a rural America problem, and this is a problem that is. I'll take an example. Right, you talk about population density, and maybe that's not where the problem is. I live in Connecticut. I probably live about 30 to 40 minutes outside of the Bronx. There is arguably no more urbane part of America than the Bronx. You can't
Right.
find a clinic if your life depended on it. Underserved America is underserved America, whether rural, semi-urban, or urban. We have a country where 83 million Americans do not have access to a primary care doc. 80% of US counties do not have access to anything that could be construed as viable care. 80%.
It's
These are these
amazing.
are these are well-published stats out there. So then you take the challenges one step further, right? And you start, and those are just the challenges here and now. And then you take it one step further, and you realize that 3 out of 4 Americans are either overweight or obese, according to the WHO. You and I both know 11,000 Americans are aging into Medicare every single day.
Mm-hmm.
And between 2020 and 2023, there was a 32% spike in Medicaid enrollment. 23 million additional Medicaid enrollees. And we know Medicaid, at face value, one of the first considerations for eligibility is where you stand against the federal poverty limit.
Right.
So you take a country where we are already hampered in terms of providing access to care, with the 80% counties not having it and the 83 million Americans. And then you talk about a risk profile where we are, to put it bluntly, getting older, heavier, and poorer. That's a very dangerous risk profile from a trifecta from a healthcare standpoint. So the level of demand continues to grow. And it's not just growing, but it's growing at an exponential pace, as dictated by what we see with Medicaid right now, right? And then you come back to challenges, and you look at the supply components that are trying to solve for it. So in today's world, if I almost think about the world, John, in, let's say, a pre-COVID and a post-COVID world, right? Pre-COVID world, even though telemedicine's been around for a while, but in a pre-COVID world, all of our orientation was, hey, I need to see a doctor. I show up at the clinic, I get an appointment, so on and so forth, right? We've got some fundamental challenges with that. It's about $2 million plus in capital outlay to stand up a clinic. It costs anywhere from $500,000 to $750K to run it year over year. But here's even bigger challenge. We're running out of clinicians as a country. This has been published over and over again by the AMA.
Mm-hmm.
If every person who needed care was provided care, we would have needed 200,000 more clinicians in 2021. We're producing 18,000 a year, all in, just a little shy of 18,000. Close to 50% of the clinicians we have in play today who are functional today are either pre-retirees or have declared themselves as being burnt out coming out of COVID. So the traditional way in which we think about clinics and a clinic-based infrastructure, a brick and mortar way of providing healthcare access has hit a ceiling. We have 18,000 a year, 200,000 needed as of 4 years ago. I mean, the math is just not adding up. So that's one challenge.
Right.
So then we go through COVID
And by the way, just to interrupt, when you
yeah,
say clinicians, it's not just doctors, it's nurses,
it's
it's
doctors,
pharmacists,
nurses, it's all
it's
of it.
across the board.
Absolutely. It's across the
Yep.
board. Absolutely. And then we go through COVID, and everyone thinks we've hit an inflection point. Now, magically, the day of telemedicine has arrived. The era of telemedicine has arrived. But I used to love watching Lee Corso on before the football games on Saturdays on ESPN, and his catchphrase was "Not so fast, my friend, not so fast," right?
Right.
Because 42 million Americans, and this is an incredibly understated number. 42 million Americans have no access to broadband, and we've been deploying care stations in places where that have 1, 2, and 3 Mbps. You don't get any video with that. So I would like to, I believe the number is probably more in the mid 60s or close to 70 million Americans who don't have access to viable broadband. Okay. And then you look at telemedicine, you got no vitals, you got no scans, you've got no biometrics. It might be good for a quick conversation with a clinician, but the experience is not a real healthcare experience. It's not the same experience as what you would get when you walk into a doctor's office. And that's where our challenge lies, right? Those are the only two modalities we have in play. Now, the other thing to call out is, again, telemedicine's been around for 18 years, and we thought COVID was going to magically make it pick up its pace. Less than 10% of all outpatient visits today are telemedicine visits. So it is, while promising, it is not delivering on what it was supposed to deliver on. And there are some very natural barriers coming back to the experience, the clinical experience, that just inhibits its growth. So the two modalities of care, of access to care that we know of as Americans, they both hit their ceiling. Yet demand keeps growing. And
Of
growing
course.
not just incrementally, exponentially. And that's what got me excited about OnMed. That's where we come in. It's not about throwing the baby out with the bathwater. It's about taking what has worked and what is the best of traditional care, marrying it, which is the best of traditional care is a psychological comfort you get knowing you've got comprehensive care in one place. The best of virtual care or telemedicine has been the rapid scalability if deployed appropriately. You marry the two together, and you've got tech-enabled hybrid care, which is OnMed. We're the only ones delivering it, which brings both of these with the ability to deliver at scale. And that's what excites me. We just got out of CES. We were at CES last week, and we won the top pick at CES.
Really?
And Vox called us the best invention at CES. Just very exciting.
Wow.
But this is the time when, as a country, and we had a media event, and I told him, I feel as a country, this is our Jerry Maguire moment. This is the time to stop kicking the can down the line and ask the rest of the industry, rest of the country, are you with us? Because we've got to do different. We can't keep doing the same things over and over and expect a different outcome. We continue to see this, right? More PE acquisitions of primary care practices. You've squeezed everything you could out of that component out of that aspect, that modality of care. We've got to do something different. This is America. We don't understand the meaning of the word no. We don't understand the meaning of the word you can't do it. That is our strength. Well, it's now. Let's do it.
Does it come down to, this is one of those age-old questions I feel like that we've asked, and whether it's in marketing healthcare services, providing healthcare services, obtaining healthcare is it because we're talking about something bigger, because we're talking about life and death, we're talking about quality of life that makes changing this industry so difficult, that has people so entrenched, or the fact that healthcare, no matter how you look at it, there's scarcity, right? And you're dealing with scarce resources. And as you talked about, more demand, it's only getting worse. Aging population will use more healthcare than the last, generation. Is that what it is? Why can't the heads of insurance companies or the heads of pharma companies or the heads of device companies look at what Jeff Bezos did with Amazon or some of the other disruptors in other industries, and try to apply that model to healthcare. What is the sticking point? Why do we look at healthcare so differently? Is it because it comes down to life and death?
I'll tell you, I feel, you know, in all candor, when I get into a healthcare conversation, John, and the person across from me says, well, it really is about the patient, I check out of the conversation because that's not true. You have to create an incredible experience for the patient. No question about that. The challenge for healthcare in America is it is it has been and it is a B2B space. Bezos, I mean, the age old, when he had his management team meetings, he'd have an empty chair in the room. What would the consumer think about our ideas, right? You can't do that with healthcare. You have to follow the money. And the money, it is a B2B space. I mean, 80% of healthcare premiums in our country are picked up by employers, the commercial healthcare premiums. And on the other side of it, you've got a country that's aging and getting poorer at a rapid pace, which is government funded. We've, I've, it's the philosophy, right? Yesterday, I thought I could change the world. Today, I got smart and realized I could change myself.
Right.
Not approaching, that's where the pragmatism comes in. I feel we sometimes get caught up in how do we re-engineer the system versus how do we take an addressable problem in the system? How do we make a marked dent in that addressable problem? And then how do we start convincing the people who have the scale to change the system that there is a better way? And that's really how we're approaching it.
So Karthik, before we get to the B2B element of it,
Yeah.
talk to me about the experience of the care station, of the OnMed Care Station. If this weren't a podcast, then I'd have you, pull up the website and go through the virtual tour, which, by the way, is very cool. Very cool.
Thank you. Thank you.
I'm envious of how good that site is. Maybe we can talk about that offline and how you were able to build that. But just give us a little insight into what the experience is like in one of those care stations.
Yeah. Let me give you a sense first before I jump into the experience in terms of the core principles that were very important to us.
Sure.
When we talk about underserved America, this is the America that has that in a lot of cases hasn't had the access to care that the rest of us have had. That's one. So there's already limiting factors that have inhibited their access to care. One. Two, this is also the part of America that in a lot of cases may not, we assume there's a level of tech sophistication, might not be there. So it was incredibly important. The design principle has been incredibly important to us to make sure that there is no aspect of it that is tech for tech's sake. We have been very deliberate about humanizing technology because, if I were to tell you without naming where this is, if I were to tell you, John, we've deployed the care station in places where there is inconsistent running water. There's third grade literacy levels, where the only viable structure in the community is the local high school, which is a little dilapidated to begin with as well. And on an average, people commute 60 plus minutes to work. You would not think I'm talking about America. These are parts of, as an example, rural Alabama that I'm talking about.
Mm-hmm.
So the humanizing of the care station and making a person who's had, in some cases, never seen a doctor in their lives in their life or has not seen one in 20, 30 years. The humanizing was very important. So the experience is quite simply you walk into the care station, you don't need an appointment, you just walk in. The, um, the door shuts behind you, the glass fogs up, you've got complete privacy. You don't have to be tech savvy. There's a 65-inch screen in front of you, which is larger than life. It's humongous. It's standing right in front of you, right there. You go and touch the start button on that. A clinician shows up on the screen. Your wait time is no more than 2 or 3 minutes, which is completely different from what you would experience in a doctor's office.
Right.
So you're standing out there. The first order of business, you stand in the middle of the it's an 8.5 by 11 care station. Think of it as a kiosk, right? So it gives you enough breathing room there. You stand out there, you stand in the middle. Your weight's it's a weighing scale. Your weight's being checked. There's a blood pressure cuff that the clinician can walk you through in terms of putting your arm through. There's a pulse ox that you can get your pulse checked. There's thermal scans going on. So there's scanning of your forehead, there's scanning of your chest. So there's any congestion, there's anything that's going on that might be causing, that might be resulting in, sinusitis, sore throat, whatever the case might be. You've got scans all over. So then you're walking the clinic. The clinician's got an EMR pulled up. They're taking a bunch of information from you. You walk them through your primary set of concerns. Let's say you've got a sore throat, or let's say you've got chest palpitations, whatever the case might be, right? And I would look at this as the right place for primary care, urgent care, post-acute, things that you would construe as everyday care, not a specialist visit, right? The nurse has a command center on her or his side where they're able to deploy a stethoscope from the ceiling. The stethoscope comes down. They show you how to hold it to your chest. While you're doing that, they're able to listen to your chest in real time. You've got a bee sting. You've got a rash. We see this, right? Dermatology continues to be the top driver of pharmacy spend. It continues to be the top driver of Medicaid as well in a lot of cases. So
Dermatology.
Dermatology. Ointments continue to be one of the highest highest utilized segments of healthcare. And so you've got, let's say you've got a rash, you've got a bee sting, whatever the case might be. The clinician can deploy a high-def camera that comes through from the ceiling. You point the high-def camera to that, they can see exactly what's going on with you and with that thing. You can point it to your throat, they can see down your throat. All the things you would do in a doctor's office. Stick out your tongue and be Willy in Free Willy, right? Be the orca. Right. Stick out your tongue and say, and right. They can look down your throat. The things that you would expect in a doctor's office. You do that. They wrap up stuff. They give you a treatment plan coming out of it that is a formal treatment plan. They can refer you to a specialist if you need a referral. They can e-prescribe to your local pharmacy as a part of that. We've been very deliberate about making sure that it's important that we are, just the way we talked about humanizing technology, it's been important to us that we are seen as a part of the community fabric. So we're in most cases in the communities we're very aligned with the local pharmacies so that the patient has the ability to get their prescription pretty quickly. They're done. There's a simple 5-star, how do you rate this visit? They do that. If they're done, the clinician unlocks the door for them. They step out. At that point, the door self-locks. UVC light is deployed by the clinician inside of the care station. UVC is known to kill 99.9% of all viruses and germs. So it completely sanitizes the devices. Every aspect of the care station is sanitized with that before the door is opened again for the next patient walking in.
It's absolutely amazing. It's just, and for those of you who are really interested in this, you really have to go to OnMed's website and go through, do the virtual tour. It's remarkable, and it's pulling all of like our best technology and putting it into one place. So what about that B2B strategy? What is it? what does the growth strategy look like? Who do you align with?
Yeah, yeah.
All of those from a business perspective in order to help people get that access. How do you deploy and how do you grow?
How do we deploy? How do we grow? We've been deliberate. Our growth model, our business model is a B2B model. The care station is being paid for by sponsors who are everyone from we've had payers, we've had providers, both we've had payers, we've had providers, we've had universities, we have had large community players. For example, one of the largest home builders in America has been actively sponsoring stations where they can put it into the residential communities that they're building. They can put it into the commercial communities that they're building as a part of that as well. This has been so. When you think about it's fascinating, right? You think about the motivation for each one of these folks. While we would like to think altruism and the greater good is a factor, I'm sure it is. I mean, everyone likes to, even in a B2B play, the decisions are being made by people. They're not being made by companies. And everyone would like to believe that they are making a difference in America by doing something like this, and they are, right? The But healthier communities are wealthier communities. It's an irrefutable fact. So when you think about it from the standpoint of payers, a lesser known stat in America is 75% of all ER visits are for non-emergent reasons. It
That's
is a
crazy.
default, it is a crazy number. Going to an ER as compared to a primary care facility is 13x more expensive. Going to an ER compared to a care station is 25x more expensive. So for a payer and for a provider, getting the patient to the right site of care not only takes care of the patient appropriately, but also ensures that people who have truly emergent conditions are not getting choked in a line where you've got non-emergent cases sitting in front of them. That's one motivator. The other motivator, as for providers especially, is as they're looking to grow into the community, as they're looking to get their brand into the community and provide care in the community. Coming back to some of the stats I rattled off earlier, it's too expensive to stand up clinics, and there's not enough docs for them to deploy in those communities, right? So we've got providers who have basically wrapped their brand around the care station, and they've deployed them in those communities. And in some cases, they're providing the clinical services. In some cases, we're providing the clinical services. But in either case, they're able to get their brand into the community and really see the care station as an extender. I think of it as something akin to, the wire, the network mesh devices we use in our homes, right? You've got your router in one place, and then you've got to put these in, you put these in these plug points across the house, and it just connects the network. It expands your network. They're expanding their footprint by virtue of deploying the care station. That's the motivator for them.
Well,
Got
that's
universe.
actually that was, not to interrupt. That was
Sure.
the model that I was really curious about. Say here in Phoenix, Scottsdale area, Honor Health,
Yep.
Honor and Banner, two of the bigger systems here in town, and Honor in particular has a lot of clinics, a lot of locations that are kind of peppered throughout the valley. Have you worked with these IDNs to say, we can save you a lot of money at the same time that we can increase access and then in turn referrals and other things within
100%.
within
We are in active conversations with a number of different players in Maricopa to be able to a spectacular county, but everything is so far apart.
I know.
Right?
I know.
And it's a tremendous opportunity to provide access to care out there. So we are in contact with a bunch of different folks out there. John, we have deployed this inside of a prison. We've deployed this outside of hospitals. We've deployed this in a community center in downtown Miami, a children's center. We've deployed this inside of the largest foster system in Connecticut. We've deployed this inside of an FQHC in Georgia. It's been deployed inside the state capitol building in Atlanta for the state of Georgia, where their employees are using this. It is going to be deployed inside of an airport in the next month. The vision for the organization is healthcare anywhere. And even in the places where broadband might be a challenge, we have now natively integrated Starlink into it to essentially diffuse the broadband limitation. We are anywhere there is an ability to plug into a wall. We want this to be a viable answer, because healthcare has never been a field of dreams. If you build, they will not come. We have to be able to deliver access at scale. We have to be able to deploy these in locations where people are showing up anyway. So even in some of these rural communities, we've put this in. So one of the communities I talked about, right? It's a fascinating community in Western Alabama. It's inside of the local high school. We have now seen 48% of the community with 35% return visits. So this is their medical home. This is where they come to get everyday care. And
the ultimate vision, right?
The ultimate vision. One of our client execs went out there for a visit, and a completely random person off the street who she had never met before realized she was with OnMed and came and told her, "I had not seen a doctor in 40 years.
Wow.
Until I came into a care station. Thank you for changing my life."
It's huge.
I can't even begin to tell you. I do life coaching for people on the side. I think we talked about this the last time together,
Yeah.
John. And I always tell people the first thing to work on is what would the first line of your eulogy look like? I would like to think that for anyone working at OnMed or at any of our sponsors who are working with us to deploy these into some of these underserved communities, it may or may not be the first line, but it's definitely showing up in their eulogy.
Well, Karthik, I swear I could talk to you about this for another hour, another 45 minutes, whatever. I just enjoy talking to you so much.
Thank you.
You clearly have a vision and a purpose behind what you're doing, and I hope you come back for a third visit and check in. It's and for those of it, I guess you can give the website for anyone who's interested in learning more about OnMed. You can go ahead and give that, or anybody who needs to reach out to you.
OnMed.com. Yeah.
OnMed.com.
Just OnMed.com. And this is the time to make a difference. The next pandemic is not an if, it's a when.
Mm-hmm.
And access and having other modalities from an access to care standpoint has to be part of our core public health infrastructure.
Couldn't agree more. And thank you again for spending so much time. Really appreciate it. And that'll do it for another episode of Healthcare Rounds. Our guest today has been Karthik Ganesh, CEO of OnMed. And as always, I'm John Marchica, your host, CEO of Darwin Research Group. If you can, give us a rating wherever you listen. If it's on through Apple, Spotify, or if you're watching us on YouTube, please rate the show and be sure to follow us. So see you next round.